All right, so let's go ahead and spend a few minutes talking about patient assessment. Our patient assessment's sort of our bread and butter for our EMTs. A lot of talking, a lot of information gathering, a lot of sort of listening to what our patients have to say, especially when we ask them questions. It's really important that we hear that feedback because it's going to mean something to us. Our patient assessments begin the very minute we walk into the door. We get a snapshot of what our house looks like. We get a sort of a visual image of what the room looks like or what the home looks like. It begins the very minute we get out of the truck while we're at our scenes. So we talk about patient assessments. We just want you to be aware of everything that's going on in and around the patient. But the minute you walk in, the minute you lay eyes on the patient, that's when things really begin to happen. For years and years and years and years, I've been telling students, sick people look sick. And I'm sure we've all experienced this one time in our life. We lay eyes on a friend or a family member or a loved one, and just they look sick. All right, their color is off. They look sort of fatigued, maybe exacerbated, a little lethargic. These are all signs that tell us that whoever we're talking to or whoever we're getting ready to deal with, I can tell just by looking at them that they are sick. We will also know that based on what their skin color, temperature, and condition looks like, whether or not we notice any obvious signs of trauma. Is our patient unconscious as we approach them? Is there any obvious signs of difficulty breathing or some sort of circulatory issues? We want to make sure that as we approach, we're really soaking in all of that data as we are getting ready to start our patient interviews and assessments. Okay, so just keep that in mind. Very first thing we're going to look at after we notice whether or not our patient has any obvious signs of injury or distress or illness is our patient mentating. And what I mean by that is our patient looking at us the minute that we walk in the door? Are their eyes alert to our presence? We're going to be sort of focusing on using that AVPU scale: awake, alert, verbal, and unresponsive. Do I have to arouse my patient with my voice when I walk in the door, or is just the mere addition of myself and my crew into this patient's home enough for he or she to go ahead and look in my direction? So please make sure you have a really solid understanding of how AVPU works. It's really going to sort of kickstart whether or not our patient is going to be somebody who needs maybe some immediate assistance or someone we're actually going to be able to talk to and gather information and data from. So AVPU, if you don't know it, spend 15-20 minutes, memorize it, and then bring it up in lab so that we can really get your laser focus on understanding how AVPU works and what we're going to be expecting from you, how that works. So after that, it just goes into just asking the question, sir or ma'am, what's going on today? Subjective information is going to be coming from the patient. Let them tell you in his or her own words why they picked up the phone and called 911 today. Let's get that chief complaint, because that chief complaint gives us somewhere to begin. All right. Otherwise, we're just sort of shooting in the dark and hoping something sort of sticks. No, let's let the patient help us so that we can help them. Sir or ma'am, what's going on today? Why did you call 911? Oh, I'm having chest pain, or I'm having difficulty breathing, or my back hurts because I fell in the garage about 20 minutes ago. It gives us a starting point. All right. So let's make sure that we let the patient tell us what exactly is going on. What is your chief complaint today? All right. I'm sure that we've all been sort of immersed in learning our airway, breathing, and circulation, our ABCs. If your patient does not need CPR, then we can just go ahead and start with our airway, breathing, and circulation. And the airway is simple. Does the airway appear open and patent? All right. Or do I see that it is obstructed? Do I have a suspicion that it's possibly obstructed? Do I hear any loud snoring, gurgling type respiration? All of these things are indications to us that, hey, our patient might have a foreign body airway. The number one airway obstruction in an unconscious patient is the tongue. So maybe we need to position them. Maybe they're unconscious and the tongue is rolling back in the throat and we get a really loud snoring noise. It's really hard for your patient to get good oxygen in and out of their face. if their tongue is obstructing their airway. So these are all things that we're looking for when we are assessing our patient's airway. And don't just assess it. Once you assess it and you determine whether it's good or bad, ask yourself, do I need to do anything about it? I mentioned the reassessment, or excuse me, the realignment of your patient's airway if you believe that their tongue is obstructing their airway. Maybe they're completely unconscious and unresponsive, and they might need something like an oropharyngeal airway or nasopharyngeal airway to help secure their airway. So don't just assess it. Ask yourself whether it needs to be treated or not. All right. So that's what we're going to be looking for our airway. Hop right into breathing. Breathing. Is our patient breathing? Let's just start with that. Ma'am or sir, I'm looking at them. Does my patient appear to be breathing? And how do we tell? We look for rise and fall of the chest. Listen, if your patient is awake and talking to you, they're breathing. So just take it to the next step. Well, if you're breathing, I need to know how many times a minute my patient is breathing. 12 to 20 is the average rate for an adult. 12 to 20 times a minute is your good average rate for an adult. Yes, it could be below 12. Yes, it can be above 20, but our sweet spot is between 12 and 20. Anything below or higher, do a little bit more of an assessment, decide whether or not you need to do something like apply oxygen. Just like I said for airway, we don't just assess. We gather the information, the data, and then we go ahead and decide whether or not our patient needs to be treated for an airway issue, or breathing issue, or a circulatory issue, okay? Looking at those respirations, do they appear labored? Do they appear to be shallow? Does our patient appear to be breathing too slow? Are they not breathing at all? The rate, rhythm, and quality of those respirations, we want to make sure we get them. If you just say, okay, well, how many times is my patient breathing a minute? And I say 22, you're like, okay, well, I got some information based on that. I'm not really sure what to do from this point. Versus, what's the quality and rate of my patient's respirations? Oh, your patient's breathing 22 times a minute and labored. It might sort of push you into a position to say, hey, you know what? My patient might need a little bit of breathing therapy. Let's go ahead and give them some oxygen. All right. Again, don't just gather the data and do nothing. Once you get the information, once you get that data, decide whether or not you need to do something more. Okay. So our airway's handled, our breathing's handled. Let's go ahead and jump down to our circulation. We're going to be looking for three things. Is our patient bleeding? If it is, stop it, or decide whether or not if it's a life-threatening bleed. What I mean by that is if they have a small laceration on their arm, please don't halt your assessment to put a Band-Aid on their arm. Is it a life-threatening bleed or is it not? So ask yourself that question. Is my patient bleeding, and do I need to stop it? What does my patient's skin look like? The skin is the largest organ in the body. And once your circulatory system starts to realize that your body is in duress, it pulls nutrients away from your skin. It starts to get it to change color. It starts to sweat. The condition of the skin changes. And that is that visual cue that, my patient does not look very good. Something is going on with my patient. So, are you bleeding? Let's look at that skin and let's go ahead and get a heart rate. All right. Just like we did for our respirations, normal range is between 12 and 20. Our normal range for adults is 60 to 100 beats per minute. Anything less than 60 is considered bradycardia. Anything over 100 is considered tachycardia. If the heart is too slow or too fast, that means it is responding to some sort of injury or illness. It's time for us to get a little bit deeper into our assessment. Let's find out what's going on with our patient. All right. So this is our ABCs. This is our interview. This is us gathering our chief complaint. This is us checking our AVPU and our mentation. It's a lot to do in a very, very short period of time. Practice this, folks. All right. There's a ton of material online and in your book, and maybe your classmates or the people that you ride with, or maybe you have a family member that's in the industry. Hey, what are some things that you guys do? Start practicing this. Go home, interview your parents, interview your dog. It doesn't matter. This is going to be what we expect out of you guys. Let's get that assessment. Let's gather that information, and let's decide how we're going to proceed with our patient. Okay? If you decide that you have to do anything to aggressively treat your patient's airway, your patient's breathing, or your patient's circulation, I want you to start thinking somewhere in the back of your head that this patient is going to be an emergent transport or a load and go. All right. And what I mean by that is let's not waste too much time on scene talking about our patient's allergies or the last time they ate anything, our sample history, which I'll go into here in a minute. Let's go ahead and get our patient going towards the stretcher, towards the ambulance, towards the hospital, because our patient appears to be sick. Okay, again, I'm going to say that one more time. If you're doing any sort of major or rendering any sort of major aid to your patient's airway, breathing, or circulation, start thinking to yourself, hey, I got to get going. My patient is going to be a load and go. They appear to be really ill or injured or sick. Okay?